Before I introduce the speaker of this year's Willard Fee Lectureship, I first wanted to mention a few words about Dr. Fee. As most of you know, Dr. Fee was the chair of otolaryngology here at Stanford for 20 years, between 1980 and 2000. He became the chair at the age of 37 and is an internationally recognized leader in head and neck surgery. In addition to his clinical contributions, he was the PI of 2 NIH R01 grants and is a member of the prestigious Collegium of Otorhinolaryngology. Dr. Fee is recognized in particular for contributions to the study and treatment of nasopharyngeal carcinoma, a virally associated head and neck malignancy. Therefore, it's very fitting that this year's Fee lecturer is another internationally recognized leader in head and neck surgery with an interest in another virally associated malignancy, that being HPV-related oropharyngeal carcinoma. Our speaker tonight is Dr. Eric Sturgis from MD Anderson. He is a full professor at MD Anderson, and he received his Bachelor of Science at Louisiana State University, his MD at Georgetown, and an MPH at the University of Texas. He completed his residency at Tulane and completed multiple fellowships, including one at Memorial Sloan Kettering, one at the Vrije University in Amsterdam, and one at MD Anderson. He's published over 185 articles in peer-reviewed journals and has been an investigator on over a dozen grants. His CV, which came to me by email, is 59 pages long, and took me a while to leaf through that. Tonight he is going to be speaking to us about his research on HPV-associated oropharyngeal cancer epidemic, and with that I'll hand it over to Eric. There's one announcement. If you could fill out the evaluation at the end and leave it on the desk, and we'll collect that afterwards.
John, thank you very much for the kind introduction. And to Dr. Fee, it's a great honor to give this lecture in your name. And thank you for the lectures you gave over the years. And a memorable one that I had the honor of going to in Chicago in the early 90s, where Dr. Fee mixed it up with my later chair, Dr. Gephardt, which was quite entertaining. But I want to thank John Ogilvie, who called me, and tell you all about John. John was a resident with me when I was a fellow at MD Anderson. Supposedly, he was a resident with me. He wasn't there like half the time because he was interviewing for otology fellowships. I think he interviewed at every otology fellowship in North America. And I was glad to see that he finally ended up with Dr. Jackler. So all that time with me rounding on the patients paid off for John. So today I'm going to talk about the HPV epidemic, and tomorrow I'll talk a little bit about the clinical side of this. And just to the residents in the room, you know, we think of head and neck cancer as a rare disease, but in the public health people don't think it's very important. But there have been some presidents, this is Grover Cleveland and U.S. Grant, who had this disease. And this is one of the Kaisers of Germany. This was, he died of larynx cancer. They're quite interesting stories if you take the time to read the history of it and the effects they've had on indeed world history. Now our program in molecular epidemiology is sort of comes at cancer with this idea of cancer susceptibility, if you look at it as a bell-shaped curve of how we respond to carcinogens. And certainly we're all exposed to carcinogens, yet most of us don't develop cancer after such exposures. Some of us may be exposed to years of, you know, we all know the stories of the person who smoked for 80 years and never got cancer. Perhaps that group is a resistant group. We certainly know diseases like xeroderma pigmentosa or people who carry BRCA1 mutations who have a hyper susceptible, and they're doomed pretty much to get cancer. But what we've been interested in is sort of a susceptibility group in the general population. And that's when I came to MD Anderson, really my interest was to study this idea, and I think we are moving forward in that area. The ideas of susceptibility to tobacco and alcohol is different between different individuals, and that's really our genetic background that affects that. And we're starting to look at some issues of thyroid and salivary malignancies, but now what we're focusing on a bit because of the change in demographics is HPV. So I just wanted to give you all a flavor of some of the other stuff we've done. We've set up a database, which I'll talk a little bit about today, with my collaborator in epidemiology, where we now have over 2,500 patients with newly diagnosed head and neck cancer, and then 2,500 cancer-free controls. We've collaborated with international groups who also have large databases and molecular epidemiology databases, and these are starting to yield some nice papers, and the groups are actually coming together to share genetic data so that you can really gain a large enough sample size and enough power to tease out some of these issues of genetic susceptibility and other issues that are more epidemiology questions. I mentioned the salivary and thyroid work that we're trying to do, and we've been looking at some clinical outcomes within this large database. But really what we're going to talk about today is our HPV work. Dr. Sincere-Pini and I published this review looking at the epidemiology and the emerging problem of HPV-related cancer, and the suggestion that we're seeing more pharyngeal cancers and tongue cancers. Now, the SEER registry mixes oral tongue with base of tongue, and I'll show that in a couple slides better. This slide shows the per capita consumption in the United States, pounds of tobacco per adult, over the past century and a half. And you can see cigarettes shown here in blue, the dramatic increase with World War II. Then the first sort of worries of lung cancer related to tobacco, which were published in the 50s. And then finally, the Surgeon General's warning in 1964. And we've seen a nice decline in per capita cigarette consumption in the United States since that time. And as you would expect, with time, we are now seeing a decline in laryngeal cancer incidence and most oral cavity cancer incidence in the United States. Again, tongue mixed with base and oral tongue here, but showing a slight increase. And then the other oropharyngeal sites with tonsil also showing slight increase. You can actually just pull this down from the SEER website, and it's rather easy interaction to have and to look at different changes over time on the website. This is MD Anderson, and this is incident cases presenting to MD Anderson with oral cavity and oropharyngeal cancer. You can see our numbers when I came to MD Anderson were between 100 and 150 oral cavity and oropharynx cancers annually, and now we've grown to around 200 to 250 oropharyngeal cancers, and our oral cavity cancers has stayed down around 150. I can tell you our larynx cancer numbers are down around 80 per year at MD Anderson. And as a proportion, this probably better reflects the change that we've been seeing. You can see the proportion when I came there was slightly more oral cavity as a percent of our patients to oropharynx patients. And now we're seeing about 50% of our patients are oropharyngeal cancer. This is just squamous cancer of the head and neck. And oral cavity has dropped to about 30% of our patients. Very nice paper I'll refer you to. This is Anil Chaturvedi from JCO 2008. And they actually went into the SEER and carefully separated oral tongue from base of tongue so that this truly reflects oral cavity sites and this truly reflects oropharyngeal sites. And this is incidence of disease, age adjusted. And you can see how oral cavity has been declining over time since the early 1980s, whereas oropharynx was sort of plateaued and now increasing. If you look at this in men versus women, most of this increase is in men, particularly white men, shown in the yellow here. And black men have been seeing a decline in oropharyngeal cancer incidence in the United States, similar to the decline in oral cavity cancer. This, from an epidemiologist viewpoint, this is just remarkable. You have a disease in which this disparity between African Americans and whites was one of the highest of all cancer sites, prostate cancer being higher. But this disparity has completely reversed in really just a 20-year period. It's quite remarkable. If you go to the website, it actually, white men now have a higher incidence than black men. The trends in Europe are similar, though they're slightly delayed, likely because their cigarette use has not dropped as rapidly as it has in the United States. And this is from our friends to the north. This is from British Columbia, showing oropharyngeal cancer incidence increasing versus oral cavity cancer decreasing in incidence. How about age? So in oral cavity cancer, we've seen declines nationally in all age groups with the exception of the very young. It's a separate topic, but one for separate discussion. And these declines are each significant. Oropharyngeal cancer has had significant increased incidence mainly in 40 to 49-year-olds and 50 to 59-year-olds. This is 5% per year. That's what that number means. This increasing incidence right here, most recently for 50 to 59-year-olds. It's pretty dramatic. Now, within our group, we've mostly, of course, our patients are going to fall into this 50 to 69-year-old group. But you can see in our middle-age group, they tend to be dominated by oropharynx patients, shown here in blue, particularly men. And many of you will recognize this problem here, young patients being dominated by oral cavity patients, particularly a lot of women. And then this other unusual group of older women, again, another discussion, but it's something I think is quite interesting, older women that tend to get oral cavity cancer. This is history of MD Anderson, the age of presentation of newly diagnosed oropharynx patients. You can see this slow decline in age over time, but in the prospective database where we have better data, our median age is about 55 now for oropharyngeal cancer patients. And this is smoking at our institution. So current smokers shown in red. This is a percent of the total, all oropharynx patients, 4,000 patients. And you can see that never smoking shown here in green and former here. And so now we're sort of matched up with all split between the three categories. And in the prospective database where we have very accurate smoking data, almost 45% of our oropharynx patients are now, in the most recent 4 years, are now considered never smokers, meaning fewer than 100 cigarettes in their lifetime. So Professor Zerhausen won the Nobel Prize in 2008 for his work that basically has proven that cervical cancer is caused by HPV. And this is a nice review article from Laryngoscope that I took this cartoon from. It shows nicely how virus gets incorporated and how that DNA can get incorporated into the host genome such that the proteins E6 and E7, so those are the proteins that are most important, the viral proteins that are most important for the cancer phenotype. E6 works to degrade P53, whereas E7 works on the RB pathway. And it's this effect on the RB pathway that results in an upregulation of P16. So that's why we can use P16 as a marker for an HPV positive tumor. It should overexpress P16. Now I'm going to switch to some behavioral data here. This is from Amber D'Souza, and this is 330 adults, and this is prevalence of HPV just on an oral swish or swab. And you can see that the prevalence, first of all, the prevalence rate is relatively low. For men, it was 6%, and for women, it was 1%. This is a point prevalence, just 1 point in time. But it goes up with the number of oral sex partners in lifetime that the person reported, and the number of sex partners in lifetime that the person reported. Also in that paper, they had a sample of 210 college-age men, and you can see that the prevalence of HPV went up with the longer time they were in college. So freshmen had a very low rate, and the seniors had a higher rate. Still pretty low at 5%. Again, that's a point prevalence. And we know from cervical data that you lose HPV, most of us would lose HPV over time. Now, oral sex partners, it goes up to, with the number of oral sex partners in lifetime, and that I'll go to this number of vaginal sex partners in lifetime. Both of those were significant. However, they also found that open mouth kissing, French kissing, was associated with a higher HPV point prevalence. I say that with caution, that has not been yet replicated in other studies, so it's a bit provocative at present, but I suspect there's going to be some other data that comes out along those lines. Amy Kramer reviewed the literature, and she showed sort of how the prevalence rate does seem to go up with the age, and how point prevalence, even for very large studies, does seem to fall into this range between 0 and 10% for most studies. These are two outliers that are from overseas, and there may be some problems with the methodology. Now, switching to tumors and HPV prevalence in the tumors, also Amy did this study, review of the literature. I will tell you, I've read a lot of these papers, and there's a lot of site misclassification in these oral cavity papers, I suspect, and also perhaps some of these larynx patients and even some of these oropharynx may be artificially low. In other words, what I'm saying is some base of tongues getting mixed in with the oral cavity and some oral tongues getting mixed in with the oropharynx, soft palate and hard palate, these sort of things getting mixed up when people who aren't completely knowledgeable about sites and site has not been recorded properly. But the point is, the highest rates do seem to be in the oropharynx. And when you look at the viral type, they're almost overwhelmingly type 16. Over 90% of HPV positive oropharynx cancers will be type 16. This was Joel Ernster. He's a private ENT guy in Colorado, and this was his trio thesis. Did a nice job. Small study, but it was a population-based study within the El Paso County of the SEER registry, and he showed that looking at archived tumor specimens, he could find more and more HPV DNA as time went on. And this is the recent article, Chaturvedi in JCO this year, which has looked at the SEER registry from LA, from Iowa, and from Hawaii, and with 4 different methodologies looking at a sample. Okay, it's not all the patients in the SEER, in those SEER registries, 271 of them, but a pretty good spread of the patients in the SEER registry, showing increasing rates of positivity over time, no matter which method they used. And this was a very important paper from Scandinavia, where they have a very nice cancer registry and tumor databases showing increasing rates of tonsil cancers being positive over time, going from the 20s back in the 70s and early 80s to almost 80%. If you look at individual papers, most of the papers from the 90s with dealing with samples from the 90s were in the 50% range that were HPV positive. And now more recent papers, and our work is showing similar numbers, it's about 70 to 80% of the tumors seem to be positive for HPV. They've calculated the incidence rate for HPV positive versus HPV negative cancers, and these are estimates of incidence rate, increasing for HPV positive and decreasing for HPV negative. That's from Stockholm, again, tonsil cancers. And this is the paper that's in JCO now, where they're able to do a similar estimate for the United States, showing decreasing rates, as you would expect, with similar to other tobacco-related head and neck cancers, declines in HPV negative oropharyngeal cancer incidence, and rising HPV positive oropharyngeal cancer incidence. And here's probably the more important slide is, This is the incidence of cervical cancer in the United States, shown here in this yellow line here. And this is oropharyngeal cancer incidence right here. And you can see right now the oropharyngeal cancer incidence in men in blue is actually now equivalent with that of cervical cancer in women. If you look at the actual number of the actual number of cases shown here, it's estimated that the annual number of cases of HPV positive oropharyngeal cancer will actually surpass the number of cervical cancers in the United States in the year 2020. So there's been all this hype about vaccination. Basically, that was all designed for cervical cancer prevention, but oropharyngeal cancer is a rising problem for us. What's the risk associated with HPV exposure? These are from serologic tests showing that the main risk is, again, for oropharyngeal cancer. Shown on the bottom two pictures there, graphs there, these two here. Again, there's going to be some misclassification in some of these older studies for oral cavity. The risk is somewhere between, in this early study, between 5 and 10-fold. When you talk about cigarette risk for lung cancer, just to give you a marker to go by, it's about 10 to 20-fold increased risk for lung cancer associated with cigarette smoking. We've looked at this in our population. This is serologic data. 43% of our patients were serologically positive. Now, you will lose your seropositivity. Many of us will lose our seropositivity over time, so you don't expect it to equal the positivity rate of your tumors. Cancer-free control seropositivity is about 13%, and we found an estimated risk of 6-fold after adjustment for tobacco and other risk factors. Now, looking at tumors, we found that our younger population, under 50, were dominated by patients that reported having never smoked and being HPV positive. The middle group was a mix of never smokers who were HPV positive and smokers who were HPV positive. And the older group was a mix of HPV positive smokers and HPV negative patients, sort of going along with some of the other data on age. This is an important study because it's the only study we have that has to do with time before looking at an HPV infection and later development of cancer. Now in cervix, we have data on time because we have pap smears and later development of cancer. So we know about HPV exposure and later development of cervical cancer. We don't have that data for head and neck cancer. But we do have this study, New England Journal 2001, using the Stockholm serobanks, where they have these huge banks of stored serum. And they were able to identify patients in that serobank who later developed head and neck cancer. And then they matched them to patients within the serobank who did not develop head and neck cancer. That's called a nested case control study. It's performed within this cohort of patients that samples were collected at some point in the past. And they found a 14-fold increased risk for oropharyngeal cancer, and that's after adjustment for tobacco. The average time from the serum being drawn and being positive and later developing oropharyngeal cancer was 20 years. So the take-home point there is most patients who have an HPV-related cancer likely were exposed to the virus quite a long time ago. This is from Amber D'Souza. Maura Gillison's a senior author, 2007. They're a very nice paper, case control study looking at the risk, unadjusted and adjusted risk for oropharyngeal cancer associated with HPV, whether it was serology, whether it was oral swabs, or whether it was a more specific type of serology. And they found rates between, these are odds ratios, between 12 and 58 shown here. So these are clearly risks, odds ratios that would be something similar you'd expect in a case control study, say for lung cancer and smoking. So this has real public health implications. They also found the risk was associated for being HPV positive, risk for cancer for being an HPV positive cancer for the number of vaginal sex partners and oral sex partners. Both of those were significant. Now, I mentioned earlier the International Head and Neck Cancer Consortium that we've been working with, and this group has put together a large sample of patients from Europe and the United States. They found similar patterns for lifetime number of sexual partners as well as lifetime number of oral sexual partners for risk for oropharyngeal cancer. There was no risk associated for oral cavity cancer associated with these sexual behaviors, larynx cancer, or hypopharyngeal cancer. In some of our own work, looking at MD Anderson patients, just comparing non-oropharynx patients with oropharynx patients, and we found that the oropharynx patients, 59% of them reported more than 9 sexual partners in their life versus 27% of the non-oropharynx group. That means oral cavity and larynx. Oral sex was more common, with 55% having more than 4 oral sex partners in their lifetime versus 17% of the non-oropharynx group. And we found suggestions for oral anal sex and then having a sex partner with a history of an abnormal pap smear, 45% versus 17%. And among the small group of female patients, having had an abnormal pap smear was more common in the oropharynx group than the non-oropharynx group. The problem with this type of study is there can be really some significant confounding, though we did perform adjustment. There can be real significant confounding by educational status, socioeconomic status. Our oropharynx patients in MD Anderson tend to be a higher income, higher education group. Our median income for our oropharynx patients at MD Anderson is $75,000, and for our non-oropharynx patients, it's about $28,000. So you could see that this simply could be a difference in a woman who is in the lower socioeconomic group is less likely to have had a pap smear, number one, and number two, to know her results, or on the previous slide, to know their partner's results. Yes, sir. So this is oropharynx patients. This is not significant p-value, but our sample size is, I would say, is somewhat limited for us, 165 versus 87. It was twice as high, though. 16% of the oropharynx patients reported genital warts versus 8% of the non-oropharynx group. No, this is simply questionnaire data. So this is just asking the patient if they've had genital warts. So genital warts, I mean, should be most commonly type 6 and 11 HPV should be the cause of that. Mora-Gilson paper from 2008 looking at the risk factors for HPV positive versus HPV negative cancer. And you can see for the HPV negative cancer, as you would expect, the number of PAC years, the risk for cancer increases with the increasing PAC years, similar for the number of drink years, increasing risk. For the HPV positive group here at the top, the risk seems to increase with the number of oral sex partners. And there was this report, and it was significant, of an increased risk with marijuana exposure, increased marijuana exposure. Again, I have to say this, we need to think of this a bit cautiously because there's likely a lot of confounding here, and you know, the honesty of people reporting and confounding in which groups are tending to use marijuana more than not. Now, I mentioned briefly at the beginning how we've been interested in genetic susceptibility, and I also mentioned how HPV seems to work through the P53, or we know it works through the P53 and RB pathways. So we started to look at, within our sample set, at variants in the P50, in other words, germline variants, variants that we're born with in the P53 pathway, and we did find an association with an increased risk for an HPV positive oropharynx cancer associated with this proline allele. This interaction was on the cusp of being significant for a significant interaction. Dr. Lee, Guojin Lee, is a young investigator in our department that we've been mentoring through a lot of this work, and he had this published last year in Cancer Research looking at another genetic variant and associations with oropharynx cancer, in particular HPV-positive oropharynx cancer, and no association with oral cavity cancer. And then MDM4 he published this year in Cancer, and this association with MDM4 variants and oropharynx cancer. And these aren't meant to be me saying that this really means that these people, this is just suggesting that there could be genetic risk, just like I talked about smoking, some people getting cancers, others never getting cancer. Most of us are exposed to HPV. The question is, why do some of us ultimately develop cancer, and trying to start understanding who's at the greatest risk. Now, there are other diseases associated with HPV, most importantly, cervical cancer. Almost all cervical cancers you can identify virus in. About 60% of those are HPV-16. And a big chunk of the rest are HPV-18. But anal cancer, vulvar, vaginal, penile cancers are all associated with HPV, oncogenic HPV. There's somewhere between 1 million and 1.5 million new cases of genital warts every year in the United States. Usually that's type 6 and 11. There's cervical intraepithelial neoplasia, again between 1 million and 1.5 million cases annually. These are huge dollars when you think of public health. And then this is just showing prevalence of HPV and various CIN, VIN warts, and then a disease that we know, respiratory papillomatosis. And I've shown just some pictures there. And I just wanted to say a couple words about vaccination. And I have no disclosures. I forgot to say that at the beginning. I did sign the paper, but just to say, Merck both of these vaccines are approved in the United States and FDA approved in the United States, and the CDC has recommended now for several years routine vaccination of girls at age 11. And just this past month, it was in October actually, that the CDC finally has now given standard routine recommendation for boys to be vaccinated at age 11. And I'm very happy that that has happened. Cervarix is first of all, Gardasil protects against type 6 and 11, but also 16 and 18. Cervarix, which is the GSK vaccine, is types 16 and 18. Supposedly, Cervarix gives a better antibody response to 16 and 18, but they both seem to be, in the clinical trials, very protective against cervical premalignancy. And as a little teaser for tomorrow, where we're going to talk about clinical relevance of this problem, this is the SEER registry, and to show you what really is hugely dramatic in my mind, we've seen really no change in larynx cancer. Some people argue maybe a decline in larynx cancer, 5-year survival in the United States. We've seen some very modest gains in oral cavity at a population level, oral cavity survival in the United States. But look at oropharynx cancer. It used to be the worst of the 3 main head and neck cancers as far as survival. And now, and if you go to the website, you can see the more recent data. It's now the best survival of all 3 of the cancer sites, and that's at a population level. This is from the SEER also. This is a nice paper. Luke Morris, who's a Memorial Fellow right now, and he's going to join the faculty up there. Luke did a paper looking at the risk of developing second cancers within the SEER data set. And it used to be, back in the 70s and 80s, that oropharynx cancer, and in purple here, hypopharynx cancer, had higher excess this stands for excess absolute risk of developing second solid malignancies. And oral cavity and larynx were lower. And here is developing second primary malignancies in head and neck, lung, and esophagus. So tobacco-related sites. Again, oropharynx and hypopharynx were the highest. Completely has switched where now oropharynx has the lowest rate of second primaries. We'll go in a little more detail on that tomorrow as well, because I think that has real clinical relevance for us. So I just want to say thank you, and if you want, I can go over a few of these questions here or take questions, whatever you want. John? Answer a question? Or? Yeah, okay. So I'm going to show something tomorrow about survival being quite different between the two groups. It's probably confounded by HPV. And something we found. And when, in sort of looking at that, we were able to find in the literature where they have done sexual behavior studies in pretty substantial population-based groups. And they show that oral sex prevalence is much lower in Hispanic Americans. Now this is globally, it's a population level. In Hispanic Americans and African American men, Hispanic American men and African American men than white men. And that perhaps may be a reason why these risks are different in these different populations. I'm not sure if that answers all of what you, Dimitri, there was another, yeah. Oh, yes, yes. Okay. So while this doesn't clearly answer the question, we do know that when a man has an HPV genital infection versus when a woman has a cervical infection, the viral load is much, much higher in a woman than in the man. So presumably, this is purely speculative, the man having oral sex with the woman would be exposed to a higher viral load than the woman. So there would be a higher exposure rate, and thus, in theory, a higher chance to get chronic infection and subsequent integration of viral DNA. Yes, sir.
Very strong.
And hugely costly disease. I mean, the monetary amount of money that's spent per patient on RRP is incredibly high. And I completely agree with you that Gardasil would be the choice. And I don't know why they designed their, GSK designed their vaccine to not include 6 and 11. There is some hope that these vaccines will have cross-protectivity with other viral types. I will say that. And so hopefully there will be some protection for people that are vaccinated with Cervarix. Most kids in the United States, my understanding, are getting vaccinated with Gardasil. It's really in the UK where Cervarix has been more commonly used. But I believe the UK version of the CDC is now recommending Gardasil, actually. Screening for head and neck cancer? So this is sort of a Wild West right now. I mean, there's just not a standard accepted way to either screen for oropharyngeal premalignancy. And as you know, or those of you who see head and neck patients, we very rarely see oropharyngeal premalignancy. It's likely because the premalignant lesion is occurring in the crypts of these tonsils and base of tongue. The premalignancy I've seen in my practice in the oropharynx is typically in a smoker, and it's of the soft palate, and it's HPV negative. So screening for cancer is probably, in my mind, not going to be feasible. And I mean, screening for premalignancy is not going to be feasible. Screening for HPV in the oropharynx, you can do it. You can actually just use the same mechanism you use for doing pap smears, the same sort of, there's a solution, you put the pap swab in and you send it off to your pathologist, cytopathologist, and they do cytopath and they do the HPV DNA testing. The problem is it's not established how effective that is at detecting positivity or not. It's thought that it's actually quite low sensitivity. The second problem of that is, okay, you get a patient, you tell them they're HPV positive in their throat. What are you going to do about it except scare the hell out of them? There's not something they can do right now that's going to affect whether they get cancer or not. Well, you could say, well, let's just vaccinate them, and that's certainly something I'm not going to make a big argument against, but remember these vaccines were developed for delivery before active infection. The risk for giving a vaccine is very low, and if a patient came to me and asked me, at MD Anderson, I wouldn't see that patient. But in practice, the risk to do it is very low. The chance that it's going to prevent their cancer, who knows? Yeah. Good question. I've not found that data, and I didn't show it, but on those tables I had, we did not see a difference in the history of tonsillectomy in our oropharynx patients versus our non-oropharynx patients. In the future, I hope to have a larger sample size to see if there's any hint at that. The problem is, the base of tongue is equally a site that you're going to get these cancers. So I'm not going to recommend tonsillectomy routinely. As of yet, no. There's no data, though, to say that it shouldn't be. The mechanism by which it works and the antibodies produced should protect against mucosal malignancies, whether it's oropharynx or vaginal, vulvar, or anal. There is data to suggest that it protects against anal dysplasia and hence should be protective against anal cancer. And I think that's how Gardasil got approval for boys, FDA approval for boys initially. I was involved with Merck in 2007 on an advisory panel, one-time meeting. That's why I don't have any conflicts. At this point, we met one time to give advice about trying to design a trial to look at this exact question. And the problem that the clinicians in the audience in the room gave was basically, we are hampered because we don't have an oropharyngeal premalignancy. So for those big cervical trials where they've showed these vaccines are safe and effective, basically they're showing they're effective against preventing VIN, CIN, and very early cancers. And we don't have that model to replicate in head and neck cancer. And so when it came to designing a trial, it was going to be huge. Mara Gillison actually is trying to get funding for a trial that would simply show that vaccination, or first of all, she wanted to show history over time for oral infection. And then the second follow-up to that would be vaccination preventing oral infection. So you say you take college students before they go to college, vaccinate them at the beginning, and 5%, could you drop that to 0%? They were huge studies, but still, I think those studies, you'd have to go look. I'd have to go look at those again. But if I recall correctly, they were in the range of 10,000 to 20,000 women. The anal premalignancy study, I think, was in the range of 5,000 to 10,000 men. You could follow them, but still, with the incidence rate, that's still not really very high numbers. That's why it would be so expensive. Yes, sir?
Why are the HPV-associated oropharynx?
This is unknown, and people have come up with suggestions about I've heard everything from the fact that the oropharynx has this very close proximity of the lymphoid tissue right into the submucosa. You don't really have the transition zone issue like you have in pediatrics, where they think that that's similar to cervical cancer, why kids tend to get the papillomas at the cords or at the larynx level. I don't think you have that transition in the tonsils or the base of the tongue. I just recently saw Sarah Pay was in Houston yesterday, actually, and gave a nice, though very preliminary, suggestion that there may be some expression differences in the oropharyngeal mucosa crypts, down in the base of the crypts, different than the surface mucosa, that put it at risk for viral infection and perhaps integration. Yeah. I was going to show a little bit of this tomorrow, and we can get on that a little better tomorrow. I think one issue is what you're hinting at about other sites. There's certainly been studies that show, both in the SEER and in European databases, showing if you have a oropharyngeal cancer, you have an increased risk for cervical cancer if you're a woman, and vice versa. If you have an index cervical cancer, you're an increased risk for head and neck cancer. What I do typically is recommend to patients, now we're talking about oropharyngeal patients, that they should have their standard cancer screening that they would normally. I don't recommend anything different for them. I don't do anything really special when I'm following patients as far as screening for second primaries, other than getting their annual chest x-ray. With the new data about spiral CTs of the chest and lung cancer in former smokers, we may be changing that. That's talking about the smoking half. So I think for the oropharynx patient that's a non-smoker, I don't really have much to offer them except to tell them that they're at lower risk for second primaries. If they are a woman, they should have their standard recommendation by their GYN for standard screening that they would recommend. Correct. If it's an oropharynx patient who smoked, I don't think we can say just because their tumor is HPV positive that we're not going to. The current recommendation is a little bit up in the air in my mind. I don't know what MD Anderson now has officially recommended for former smokers. We're getting a new, more spiral CT so we could handle the volume. And I suspect we're going to be doing more spiral CTs for patients who are smokers, screening for second primaries of the lung. So if they're a smoker, I think that's going to come into our practice. If it's an oropharynx who's not a smoker, I'm not screening them. I'm not going to recommend that to them. For larynx patients, of course, we've long known that lung is the #1 second primary site for larynx patients. Okay, yeah, okay, now I sort of see where you're going. Our practice is not, we don't do a standard pan endoscopy in the operating room for head and neck cancer patients. So that's not part of our practice. I understand and have read a lot of the data that suggests it might be effective. So yes, if their initial workup, my exam in the clinic, my endoscopy in the clinic, my whatever distant metastasis workup I've done is negative, I'm not recommending anything else other than routine follow-up with their general physician. Well, that's a lot of the reason why that the cervix seems to be an important spot for HPV. And people have theorized, because if you do PET scans on healthy population, you will see the tonsil, base of tongue will typically light up. Chronic inflammation in the area and perhaps break in the mucosal barrier and easier access to the basal cell. It's the basal cells that need to get the incorporated viral DNA. That seems to be what's important to get a persistent integration. Yeah, that is actually, I glossed over it because I don't believe it. And it's not my data, and Dr. Gillison didn't make much of it either. This has been talked about before. This is HPV negative patients. And the risk is associated with number of teeth lost and increasing incidence. The problem is, the longer you smoke, the more you smoke, right? You're going to have a greater risk for having dental decay and loss of teeth. So this, even though they supposedly adjusted in here, I think there's some residual confounding related to the hygiene of the patient that's actually we're seeing here. That's HPV negative patients. Risk for HPV negative cancer. This is risk for HPV positive cancer on these upper panels. Yeah. Dr. Fee? Yes. 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 If you look at the epidemiology literature on it, and if you look at, we've written, sort of gone through the criteria. Bradford Hill, for those of you who don't know, were British epidemiologists, and I think they got knighted or whatever. They had a wonderful, very logical approach to saying something causes a disease. And there's a list of criteria. It's a classic thing you study in epidemiology. It's very logical, and it has both the scientific side. There's a point where you have to have basic science evidence. You have to have reproducibility of data. You have dose response data. All these different things come together. And there's papers, both we've written in our papers, Maura Gillison's written in her papers, where they go through those criteria and point out how well they've been met. Now, I will say that, you know, some of the criteria are better met than others, but it's pretty well accepted now that for oropharyngeal cancer, HPV is causative. I think larynx cancer only very, very rarely is caused by HPV. I'll show tomorrow in some of the survival studies, it's very rare in careful, proper HPV labs where you see HPV positive laryngeal cancer. The cases I've seen are patients that have had long history of RRP, that have had papillomas known for years, and ultimately they have cancer develop. Thanks, John. Thank you.